Hey, everybody. Welcome to our third annual Global Foot and Ankle Town Hall. As you know, every time this time of the year, we assemble a tremendous number of faculty from around the world to share their experience and expertise in foot and ankle. This year, we're going to be focused on trauma. Before we start, I wanted to kind of go through a few things. This foundation, the Parekh Family Foundation, which is bringing you the Global Town Hall, was founded in honor of my parents who have passed. And it was really to embody the essence of what they really wanted to do in life, which is to give back to those around them. We started our foundation way back about 14 years ago, where we began our efforts in India, trying to elevate foot and ankle care in India. And at that time, these three surgeons were really the pioneers of foot and ankle in India, the only three who were really doing a lot of reconstructive work. And so we came in as a foundation and really tried to train, educate, and treat foot and ankle patients in India through charitable surgeries. From there, it expanded to physical therapy. My wife's a physical therapist, and she started training and educating physical therapists in India, and it's grown over time. We have been to various parts of India throughout the time. Over the last 10 years, we've also been through other parts of the world, namely Mauritius, Kenya, Chile, Turkey, and it continues to grow. Our foundation was stifled, like most people, by COVID, but it brought opportunity, explosive growth of virtual meetings, the adoption of virtual platforms, and the ability for our foundation to reach a global audience all at one time. So we pivoted in 2021 and brought you the Global Foot and Ankle Town Hall. The first year was more of a generic foot and ankle course. The last year course was focused on sports. And this year we're focused on trauma. So over the course of the next 24 hours, you're going to hear from experts around the world talking about the basics and the advanced concepts of trauma. You're going to learn from these faculty. You'll learn from their mistakes, learn from their cases. This is meant to be interactive, so feel free to drop questions in the Q&A box. This is open to anybody around the world. So whether you're a healthcare provider, a patient, and a curious individual, you can ask these questions to our faculty. We have to thank all of the organizations that helped to make this possible, from our platinum, gold, and silver sponsors. And finally, I want to thank the 100 faculty members from around the globe who took time out of their family, friends, and their personal lives to be part of this meeting over the next 24 hours. So I hope you enjoy what you're about to hear, and I'm going to kick this off and give this to Dr. Kadakia, who's going to be talking about talus fractures. This hour is sponsored by CurveBeam AI. Thanks, Rishin.
All right. Hope everyone can hear me here. I'm Rishin Kadakia. I'm one of the orthopedic foot and ankle faculty at Emory University in Atlanta, Georgia. I want to thank Dr. Parekh and the foundation for helping coordinate this event. There's certainly a lot we can learn from each other. And I really look forward to this kind of unique global opportunity to have discussion about, the various types of traumas we treat. There's not really a better way to get us kicked off tonight than starting with talus fractures. These are probably one of the more complex and challenging fractures we treat, not just due to these being tough cases from a technical perspective, but also because these injuries often have, long-term consequences that present their own challenges with regards to management. I'd like to thank and welcome the surgeons with me on this session. Dr. Jie Chen, who's an assistant professor at the University of Texas in Galveston. Dr. Chike Akoh, who practices sports medicine and foot and ankle surgery with Regenerative Orthopedics and Spine Institute here in Atlanta. And Dr. Rahul Upadhyay, who is the director of the Foot and Ankle Center at the Rajasthan Hospital in Jaipur. So with that, we'll get started. So brief outline, we're going to go over a few cases today, talk a little bit about the background and anatomy of talus fractures. What are some important considerations with regards to surgical management? We'll discuss some of the outcomes of surgery and common complications. We'll touch base on how to manage these complications, and we'll come back and finish with our cases. So to start with case one, this is a 45-year-old female, sustained a closed injury to her left ankle after falling from a height. She was mountain climbing at the time. She's otherwise healthy, non-smoker. This is a closed deformity to the left ankle, and she's neurovascularly intact. She went to the ER. She was reduced in the ER, and they did a great job reducing her. These are her post-reduction splints and her CT scan images. You can see here she has a talar neck fracture with this separate dorsal fragment and comminution here medially that we commonly see with these injuries. So we'll come back to that at the end of the talk. So case two, a little different. This is a 28-year-old male who also fell down some stairs, but not as high of a energy mechanism. He's otherwise healthy. And on his plane radiographs, you can see here that he's got this minimally displaced talar neck fracture. CT scan here demonstrates it's not truly a talar neck, but there may be some extension here into the talar body. So we'll start with a little background on talus fractures. So these are relatively uncommon injuries. About 3 to 6% of fractures in the foot are talus fractures. The most common cause here are car accidents. However, you can see them with a lot of high energy mechanisms, so motorcycles, fall from heights. Interestingly, the diagnosis here can be delayed. A lot of these patients have other injuries, and sometimes this can be missed. Furthermore, there was a study that demonstrated that plain radiographs only had a 74% sensitivity for some of these injuries, especially those like in our second case that are somewhat non-displaced. These are more common in males. There's a broad age range here. The most common type of talus fracture that we see are talar neck fractures that comprise about 50% of these injuries, with talar body coming in at second and around 13 to 20%, and talar head injuries or fractures being less common. So thinking about the anatomy, there's three portions to the talus. There's the head, body, the neck. The lateral process and posterior process can commonly be fractured as well. This bone itself transport loads from the foot to the tibia, which is why we often see this injured in axial load, high energy mechanisms. There's 5 articulating surfaces here with about 70% or over 70% of this bone covered in articular cartilage. And this is important because there's not a lot of soft tissue attachments to this bone. So, if the blood supply or the network of blood supply gets damaged here, there's not a lot of ways that blood can get to the bone as it heals, which is why we often see avascular necrosis with some of these injuries. So looking at the blood supply, again, all 3 of the major vessels contribute here. They have a various number of branches, and they form this complex network of vessels around the talus here that you can see both from the lateral side and the medial side. Thinking about the blood supply, the artery of the tarsal canal is the main contributor here. It's a branch of the posterior tib, supplies about 2/3 of the body. The deltoid branch from the posterior tib will supply medial 1/3 of the body as well. So the posterior tib itself is kind of the main contributor to the blood supply here for the talus. There's also the tarsal sinus artery as well that supplies some of the lateral talar body. There was an interesting study, an MRI-based study that looked at the blood supply of this bone and found that the posterior tib supplied about 47% of the blood supply, which is a substantial amount here. And really when they looked at it in 4 quadrants, the posterior tib was the main supply except for the anterior medial portion, which is supplied by the anterior tibial artery. So, lastly, thinking about classification, again, it depends really where the fracture is within the talus. Talar neck fractures being the most common. Most of us are familiar with the Hawkins classification, type 1 being non-displaced, type 2 fractures that involve subluxation into the subtalar joint, type 3 involving both the subtalar tibiotalar joint, and the dreaded type 4 involving subtalar, tibiotalar, and talonavicular joints. This is a good classification system, in addition to the fact that it can communicate this well between surgeons and providers. It also provides prognostic information. We know that the higher type in the Hawkins classification, the higher risk of development of avascular necrosis. Unfortunately, the same can't be said with regards to classification systems for talar body fractures. These are just not as common, and the Classification is more descriptive. There's a few classification systems out there. The Sneppen's classification, looking at this up here on the top right, group 1 tend to be more osteochondral injuries. Group 2 injuries have one plane with their fractures, so either axial, coronal, or sagittal. Group 3 fractures are posterior process injuries. Group 4, the lateral process, and then Group 5 are crush injuries. I don't really know of an official classification system for talar head fractures. Again, these are not common injuries. So with that, I'll hand it off to Dr. Akoh. Who's going to go over some of the surgical considerations.
All right, thank you, Rishin, for that introduction. My name is Chike Akoh. I'm practicing here in Atlanta, Georgia, and I'll be talking to you all about surgical considerations for Talus. So some of the old dogma associated with the management of Talus fracture includes the fact that it was previously thought that Talus fractures were seen as a surgical emergency where urgent reduction and fixation was required. However, some of the new data that has come out of the Seattle group has demonstrated otherwise, as this fracture does not truly represent a surgical emergency, as long as there's no evidence of subtalar or ankle joint dislocation. So what are the goals of surgery? Goals of surgery are several-fold. They're number one, to restore the talus anatomy. This in turn helps preserve the joint biomechanics across the subtalar and transverse tarsal joints. And then thirdly, you want to preserve blood supply so that you can maintain adequate vasculature for healing. When planning on addressing talus fractures surgically, the one thing that is paramount is that preoperative planning is key. And oftentimes you should utilize CT imaging as well as 3D reconstruction to assess the nature of the fracture pattern, to assess for signs of comminution and joint subluxation, as these factors can change your management and hardware options. So we'll start off with the surgical management of non-displaced fractures. So for these fractures, I typically utilize a posterior lateral approach. Positioning these patients, I usually utilize a lazy lateral decubitus position. And then I make a formal 2-centimeter incision along the lateral border of the Achilles tendon. At this point in time, I would then protect the sural nerve and then incise the crural fascia until you get down onto the posterior aspect of the talus. So when fixing these fractures through the posterior approach, I utilize either 3/5 or 4/0 screws. I've since have actually gone to utilize headless screws to minimize risk of posterior impingement across the talus. And when firing these screws, you want to utilize orthogonal fluoroscopic images intraoperatively, including a lateral of the ankle as well as a canal view, so that you can make sure that you're going along the talar neck. So why not fix these non-displaced fractures from the anterior approach? The reason is that it's been shown through various biomechanical studies that fixation through percutaneous methods anteriorly can lead to an aberrant path of the screw, as it's not truly perpendicular to the fracture line. This can then lead to a malreduction and plantar gapping of the talus. So when we talk about surgical management for displaced fractures, we have several approaches at our armamentarium. The stalwart approaches include the lateral and medial approach. For the lateral approach, I utilize this approach for extraarticular talar neck fractures. The approach allows me the ability to assess for a good cortical read, as typically the lateral side of the talus has less comminution than the medial side. Additionally, if there's evidence of subtalar debris on CT imaging, this approach affords you the ability to clean out the subtalar joint. And then additionally, if you have evidence of ligamentous laxity and increased varus talar tilt, you can perform a Brostrom procedure through this approach. So these are some intraoperative pictures illustrating my lateral approach. Again, I make a longitudinal incision from the level of Chaput's tubercle at the anterolateral aspect of the distal tibia towards the base of the fourth metatarsal. I then achieve hemostasis, and then I incise the fascia overlying the extensor digitorum brevis, and then I tend to split this to get down onto the lateral aspect of the talar neck. Once there, I then perform provisional reduction and fixation with a series of K-wires. Oftentimes, you may need to joystick the fracture fragments depending on the amount of comminution. And then you want to really take your time to assess both clinically and radiographically that you've obtained adequate reduction. And then in regards to plate fixation, I typically utilize mini frag non-locking screws if there's no evidence of comminution. However, if there's evidence of comminution, then I will elect to utilize locking screws to maintain the length. Now, when you have trouble with reduction through a lateral approach only, then the next step would be to open up medially. So the medial approach allows for the surgeon to assess for dorsomedial comminution along the talar neck. It'll also allow for the surgeon to place adequate hardware so that there's no concern for future varus collapse of your talus fracture fixation. And then if there's evidence of extension of the fracture fragment into the talar dome, then the medial approach affords the ability to allow for the utilization of a medial malleolus osteotomy to achieve better visualization of the talar dome fragments. So my interval that I use for my medial approach is along the medial malleolus and the intervals between the tibialis anterior and tibialis posterior tendons. Typically, I retract the saphenous nerve and veins, and then I really am mindful during my dissection to not violate the deltoid ligament, as this tends to be the last patent vasculature in a situation where you have a displaced talus fracture with subsequent subluxation of the subtalar joint. So in regards to implant choices from a medial approach, again, given that this area usually has more comminution, I tend to utilize either a locking mini frag plate or a 5/0 cannulated fully threaded screw to maintain the medial length of the talus to, again, prevent varus collapse. I tend to, if I can, avoid plating, again, because that leads to more soft tissue dissection and possible disruption of the deltoid artery.
All right. Thanks a lot, Rishin, for inviting me to speak on this panel. My talk is going to be on the talus fractures, outcomes, and complications of these injuries. So as we all know, we've all learned that the outcomes for talar neck fractures historically have not been great. But this talk is mainly going to be aimed at shedding maybe some light on some newer data that may suggest that the outcomes are not as bad as previously thought, and also talk about some risk factors for some of these bad outcomes. So this is a paper from 2004, GBJS, kind of an older paper that talks about the outcomes of talar neck fractures. It was a retrospective review of 60 fractures, and they found basically a 50% rate of AVN with 30% collapse of the dome and a 50% rate of arthritis. Despite this, 71% of patients could return to work, although their outcome scores were significantly lower across multiple domains. They did associate AVN with comminution and open fractures and possibly initial displacement, but interestingly enough, they did not find an association between delayed surgical time and the Hawkins classification score, or whether or not there was talar body extension. And they did note in the study that perhaps they were underpowered to detect this association. So this is a case, a 52-year-old individual with a motorcycle collision going 45 miles an hour. You can see on the x-ray a comminuted displaced talar neck fracture. Here's a CT scan showing subluxation of the subtalar joint and extension of the fracture into the talar body. And kind of begs the question, do these things matter when it comes to the development of AVN? Does extension into the body matter, and does the Hawkins classification matter? This is the pictures intraoperatively of the fixation. You can see the reduction, I think, is pretty adequate. However, 1 year later, this is the follow-up X-ray. You can see the development of sclerosis across the talus, and you can see some collapse of the bone as well, and breakage of one of the screws. So it appears that they've developed AVN. So what do recent studies suggest about AVN? This is a paper that came out in 2014 from GBJS, and they looked at 80 patients with fractures. And they found that, as opposed to the previous study, only 25% of these patients developed AVN, and only 14 of these patients had collapse. And what they found in this more updated study is that there were no cases of AVN with Hawkins 1 and Hawkins 2A type fractures. And they classified 2A fractures as ones with subtalar subluxation, but not dislocation. They found that the timing of the reduction or the surgery was not correlated with AVN, and there's no difference between open and closed injuries. And then the other question is, does it matter whether or not the fracture extends into the talar body? This study just came out in FAI, I think last month or maybe even this month, the Association of Talar Neck Fractures with Body Extension and Risk of AVN. So in this study, they looked at 137 fractures, so one of the larger studies that are out there, and they found that in 80 fractures with involvement of the talar neck only and not extension of the body, the rates of AVN were about half of those compared to fractures with extension into the talar body, about 50% versus 20%. And also fractures that extend into the talar body at higher rates of collapse and non-union as well. So the odds ratio of AVN, if the fracture extends into the body, is about 3.5 times, they said, versus those that did not. So another complication that happens, the most common complication actually, is post-traumatic arthritis. So most commonly this involves the subtalar joint, but can also be in the tibiotalar joint and also the talonavicular joint. And in that study, they showed that with fractures that had increasing Hawkins classification and also fractures that had extension into the talar body, the rates of post-traumatic arthritis were significantly increased. So this is a patient, 31-year-old, going 75 miles an hour and got into an accident with you can see a dislocation and a talar neck fracture. And this is a CT scan showing extension of the fracture into the talar body as well. This was the images from the surgery. You can see pretty good, pretty decent reduction. And on the left is an immediate postoperative radiograph from the surgery. On the right is a radiograph taken 1 year later. And again, you can see some sclerosis of the talus, and you can see the development of some arthritis, particularly at the talonavicular joint and some at the subtalar joint as well. Other complications that have to be mentioned, varus malunion is a commonly known complication. Oftentimes this is due to the medial comminution that allows it to collapse on the medial side. So ways to kind of get around this, if you have a dual incision and you make sure you're adequately reduced on both sides, that can help. Getting appropriate imaging, like the canali view during surgery, can help. Of course, as Chike mentioned, having appropriate hardware replacement to prevent medial collapse. And then finally, we have to mention wound complications, which can also happen in these fractures. So in summary, I think the recent evidence suggests that the rates of AVN are lower than previously thought, and perhaps part of this is the use of dual approaches, the more attention we have to getting an anatomic reduction, and perhaps more careful soft tissue handling. And the studies show that AVN is associated significantly with subtalar joint dislocation, although maybe not subluxation, greater Hawkins classification, and also extension of the talar body is a very important prognostic indicator. And as we all know, there's very high rates of post-traumatic arthritis. Thank you.
Thank you, Rishin, for allowing me to speak on this topic. So the talus fracture and the complications. Now, it has been seen that the complications of a talus fracture may be because of the fixation or maybe because of inadequate fixation or because of the misdiagnosis itself. So the range of complication might range from the a very mild early arthritis, a late collapse of the fixation, AVNs to the various small union of the fracture, and it may have drastic complications like severe cavovarus deformity of the foot and patellar arthritis, and it depends on what kind of fracture pattern it has been to start with. So we'll present a couple of cases that shows various complications of these fractures. This is a 60-year-old male who had a history of twisting injury to his foot due to fall from the stairs. He was treated for a simple sprain at some clinic, but he had continuous pain and swelling and progressive deformity over his foot. So earlier the deformity was very subtle, but over the time, the deformity started increasing, both in terms of its presentation and in terms of symptoms. So he presented to us nearly 6 months after with an old and missed neglected talus fracture with associated dislocation of the subtalar and talonavicular joint. And that led to this cavovarus deformity of the foot. If you see here, there are a couple of findings which were easily missed during the initial assessment. And we can easily see there was a dislocation of the talonavicular joint as well as a gross subluxation of the subtalar joint also. And overall, the entire ankle joint was anteriorly subluxated. So these were the missed injuries. Also, if we look closely, there is a talus head fracture as along with the dislocation from the talonavicular joint. So this was quite a complex injury, and it needed adequate reduction, primarily at the time of presentation to the clinic, and that could have given a better result. But since we missed this injury, so there were a lot of complications. And when we evaluated it further, there were other associated injuries like lateral process of the talus fracture. The subluxation of the subtalar joint was there. We could see the navicular fracture also involved associated. And there was a displaced talar head fracture. Overall, a patellar arthrosis was bound to develop in this patient. By the end of 6 months, he presented with this deformity. So we went ahead, and our purpose to operate this patient was to control the deformity as much as possible and provide a mechanically aligned foot, along with making sure that the pains of this patient is settled. So our approach was to do a triple arthrodesis of this patient to get aligned ankle as much as possible. So we opened laterally, tried to reduce the subtalar joint. Now, after 6 months, it was very difficult to get the talus body back into its position. And once we were able to get it back to as normal as possible, we did a temporary transfix with a KVIS, and a definitive fixation was done. Now, while we were doing it, we also found that a part of a displaced talar head was found right over the cuboid, so the displacement was quite gross. So we had to replace it back to make the alignment better. And then finally, we did a fixation and the fusion using a mini plate and the cancellous cannulated screws. So this was the intraoperative correction that we could achieve. And we were able to achieve a relatively good plantigrade foot in this patient. So this is nearly 2 months post-op. So we see there was still some amount of anterior subluxation, but overall the deformity was improved. The pain had improved over this period of 6 months. So in a nutshell, this injury needs to be diagnosed early, and we have to make sure that we do not miss the associated patterns of dislocation in talus fractures, because it has drastic complications in terms of deformity, in terms of pain, in terms of overall outcomes of the patellar joints. Another case that presented to us was this young 26-year-old male who had a road traffic accident, and he was primarily managed in a medical school where the appropriate reduction and fixation was attempted. There were a lot of components of this injury. If you see that there was an avulsion kind of fracture of the distal fibula. Now there was a large injury of the medial talar dome, and if you see in the lateral view, there was a big chunk of this bone which was seen, and it was a part of the talus dome, which subluxated, which actually dislocated out of the ankle joint, and it was not very much clearly visible on the anterior posterior fins. So in the primary management, they missed this large piece of the bone, and it had been there lying like this for nearly 6 weeks. Now after this, the patient started walking and he had persistent pain. So we evaluated him further just to make sure to locate that we were able to locate what exactly the space is and where it had to be put back. And we could see that there was this large anterior fragment which was lying outside the joint space, outside the ankle joint. And that was the main reason for the symptoms that patient presented with. So these were the missed pieces that were lying outside the ankle joint. So while we opened this, we could see this large piece of the talus body, which was anteriorly, and this was a large gap, a large defect in the talus body, which was present because of this. So because he was a young guy, we decided to try and attempt a joint salvage, and we could place this back together in quite anatomical position, nearly normal position, and we fixed this with a headless compression screw. So given this young age, and since the cartilage still looked quite intact, we wanted to salvage this joint. So again, the take home from this case is that the missed injuries are quite common, and we should be able to assess and point out all the defects, all the associated injuries. Another example is this 32-year-old male who had a history of fall from height, and he presented in ER. And quite commonly, we'll see that most of these patients who present with talus fractures are young. They are associated with high velocity injuries, fall from height. And so this patient, he presented to ER with this presentation, type 4, complete extrusion of the talus from the joint. And this talus was lying outside the ankle joint. So a primary reduction was done. They did a good job by reducing it back, but again, the patient was well explained about the complications that might arrive due to this injury. And the complications could be as drastic as a severe patellar arthritis. So after 6 months, the patient had severe pain, and he continued to have severe pain over his ankle joint. And we evaluated him further, and we saw that he already had a severe edema of all the joints, rather the patellar area. The joint space had started to decrease. There was arthritis mainly in the subtalar and talonavicular, not as much as in the ankle. But the pain was really, really severe. So we waited for some more time, nearly 3 to 4 months. And 3 to 4 months later, the presentation was much more severe. The joint space had already disappeared. So finally, we had to move ahead and do a patellar arthrodesis in this patient to relieve him of his symptoms. So overall, the complications of talus, as we had discussed before, range right from its management, right from its neglect, and right from its inadequate management. Thank you. Over to you, Rishi.
Thanks for that. What we'll do now is we'll kind of go back to some of these cases. Talk a little bit about how we address them, what some of the challenges were. Hopefully, we'll stir up some discussion, some questions, and then at the end, I think all the panelists have some questions to help initiate some discussion as well. So, coming back to this first case, again, this was a 45-year-old. Otherwise healthy female, was mountain climbing, fell, and sustained a high energy injury to her ankle with this complex talar neck fracture. So, this was addressed with a dual incision approach. Again, looking at her radiographs and her CT scan here, she had medial comminution. And again, this dorsal medial fragment that was separate from the talar neck fracture itself. So addressing this through a single incision just wouldn't be possible to get an adequate reduction. Again, so a dual approach here, as Chike had described, was utilized. He used a locking 3-5 plate for the lateral aspect here of the lateral talar neck. I like to use locking screws for this. I don't, cortical screws are fine if that's what you choose to use. I think the bigger thing here to be careful about is compression medially, as Chike had mentioned. So I'll use a fully threaded screw here to make sure I don't get any compression, because what you don't want is for this to fall into varus, largely because of that comminution medially. The separate dorsal fragment was challenging to address, and I think it kind of speaks to how different all of these talar neck fractures are. All of them, while they do fall into a certain type of Hawkins fracture, have some distinct, unique differences that make them challenging. And this dorsal fragment was tough to control and hold reduced. We ended up having to KY fix that piece first before we were able to attach the whole head and neck back to the body. And we used a separate screw, fully threaded screw, inserted in a lag by technique fashion to secure that fragment down that you can see here. So overall surgery for her went fine. The dual incisions sometimes they can be daunting in the sense that it appears you might not have as wide of a soft tissue envelope, but I think it's important to space them out adequately, but to have these two incisions in the right places to be able to see what you need to see. And that's an adequate reduction, which for these injuries is the main reason you operate on them. Post-op protocol, I usually splint these patients for 2 weeks until the incision has healed. Post-operative stiffness is a real problem for these patients after these injuries. So once their incisions have healed, I usually transition them to a boot and let them start some gentle ankle range of motion. I think the idea of casting for longer or immobilizing them longer to protect your fixation is reasonable, but it's a balance of protecting your fixation versus allowing adequate motion, because ultimately, even if it heals, if they're quite stiff, functionally, they may not get a good result. So again, I'll transition them to a boot once their incisions have healed, but keep them off of it for about a total of 8 weeks. Now, this can be longer for certain patients, depending upon their biology, if they're, patients that I fear may not heal well. These are images here, 6 months on the right. Her fracture has healed quite well. One of the challenges that, with her was that she's developed a lot of post-operative stiffness, particularly at the ankle joint. She lacks about, maybe 10 degrees of dorsiflexion compared to the contralateral. And this is even with starting her, at 2 weeks once the incision healed in a boot to start motion. So, it'd be interesting after this to, hear from the panelists to see if this is something that they've experienced and kind of what strategies they have for this. So I'll pass it off to Jay for the next case.
Okay, all right, going to my case. This was a 28-year-old female. She had a low energy kind of fall down the stairs, and I knew Rishin would show something crazy, so I chose kind of a more basic case with minimal displacement. But what I really wanted to point out with this case is some of the evidence I was alluding to earlier, talking about how involvement of the talar body portends to potential development of arthritis. So again, on the left is the initial radiograph, not much displacement, but on the CT scan on the right, you can see extension of that fracture into the talar body. So this was a case of my partner's actually, and he performed an ORIF, as you can see pictured here. And I think the reduction obviously wasn't much displaced to begin with, but I think obviously it looks pretty good. So then this patient, 1 year later, after my partner fixed him, had the onset of anterior ankle pain. And the x-ray on the left is from the initial surgery, and the x-ray on the right is the x-ray at 1 year. And you can see the patient did not develop AVN, but you could see the development of anterior ankle osteophytes on the talar side and on the tibial side as well, compared to what the initial x-rays looked like. I think this had to do with the fact that the fracture extended into the body, as the evidence is more and more pointing towards. So this patient was referred to me 1 year after the initial surgery, and the X-ray on the right is what I did, which was just an arthroscopic ankle debridement. Given that she already had medial and lateral incisions, I didn't want to make another large incision, so I just debrided the osteophytes through a scope. And the patient is doing extremely well and has her dorsiflexion back and does not have anterior impingement pain. So again, this case isn't the craziest of cases, but I just wanted to again show that even though you have a non-displaced fracture, it can still put the patient at risk for arthritis. I think that needs to be emphasized.
All right, thanks. I want to, if everyone on the session can hop on, I want to thank everyone for taking the time to put this together. Just to kind of, spark a little discussion here. I've got a few, things that came up as I was kind of listening to people's talks. One issue, obviously, with talus fractures, talar body, talar neck fractures, is the development of AVN. I think all of us who treat these are, good to counsel patients on the risks of these occurring. And, oftentimes it's easier for us to say, hey, this is one that might get AVN versus not, give them good percentages. What about with timing? Everyone on this, what do you guys tell them for timing? I think it's a common question that I'll get from patients with these injuries is, if this is going to happen, when will it happen to me? If it happens, right? Would love to hear y'all's thoughts on that. Chike, I think you're muted.
I think this is something that it needs to be monitored for years. I mean, AVN can happen. 1 year X-rays can look fine, and 2 years can look okay, and all of a sudden 3 years out, you might see some collapse of the talus. So I've seen cases where you don't see the AVN until years after, and that's probably not the norm, but I have seen those cases. So patients might not be out of the woods after 1 or 2 years.
Rahul, what about in India? How do you guys counsel patients on this, or are there any particular instances where you'll counsel them differently about the development of this and the timing of this occurring?
Not differently particularly, but we do keep a longer time period to monitor these patients, and we do give them a guarded prognosis. It's not the initial 6 weeks or 3 months that what says that you have to see the Hawkins sign and decide whether it's going for AVN or not. And we have seen that for a period of 2 to 3 years, these patients do pretty good, and then suddenly one fine day they'll come with a collapsed ankle and severe pain. So almost all the patients, unless it's a type 1 or a nearly undisplaced talus fracture, I do counsel them that we need to have a regular monitoring for maybe a longer duration of 2 to 3 years, and then maybe we can give a final verdict as to how you are going to proceed over the time. And like Akoh said, that you really cannot predict a time frame for these fractures. When are they going into the AVN? When are they going for a collapse? And sometimes you see that even if it has not yet developed, this arthritis, the early arthritis, or even the stiffness of this ankle, this is going to be more troublesome for these patients rather than the collapse itself. So I would keep a very long time frame for these patients to follow.
Hey, Rishin, I have a question for you. You're kind of a big 3D printed person. So when a patient comes and they have AVN of the talus without collapse, what do you tell those patients in terms of the total talus replacement? When do you tell them you think the time is right to pull the trigger on that?
Yeah, I mean, I think that's a good question. 3D printing, I think, is provided some opportunity to manage this problem in a way that we couldn't in the past. I think the challenge here is we don't have great long-term data in the U.S. yet about how these implants do. So I always tell patients that this is something we're going to try. It's an opportunity to offer them this, but that it's a guarded in terms of we just don't know how these will do long term, right? I don't think in terms of pulling the trigger, it comes down to how diffuse their AVN is. Do they have any arthritic changes? The way that these implants can be designed now is even if they have some collapse of the dome or adjacent joint arthritis at the ankle or subtalar joint, these implants can be designed to be coupled with an ankle replacement or even coupled with a subtalar fusion. I've had some patients that do pretty well. I had a lady that had terrible AVN that we did a ankle replacement 3D talus with a subtalar fusion, and she's done pretty well. I mean, I think the challenge here is we don't know which of these patients will do well, which won't. I think it's expectation management. When we looked at a case series of these with Dr. Parekh at Duke, I think the younger patients tend to struggle more just because I think their expectations of what a talus replacement is are different. It's not something you can get back to high impact activities with, but you can be quite functional from a pain control perspective. But for younger patients, that might not be enough,
Right. So given that we can match a total talus with a total ankle or a subtalar fusion, like you said, do you think there's any value in trying to quote unquote, get to the talus before the development of arthritis, since we have these other resources and techniques?
Yeah, I don't, acute total tali or doing a total talus early in the setting of talus fractures that might either have early AVN or AVN without collapse. It's not something I would certainly consider. Now, that being said, it's kind of a gray zone. I think there's different viewpoints on this. As we know, AVN can be treated conservatively. Before all of the surgical treatments, cord decompression for early AVN, all this. I mean, the earliest literature on it is non-weight bearing, treating patients for prolonged non-weight bearing. Not to say that you would do that, but there are avenues by which it can get better symptomatically without having to rush to a total talus right off the bat. I think the problem is if you do a total talus too early, you kind of start yourself down that path, right? And I think the longer you can wait, the older the patient gets, the better for the patient long term. Because again, we just don't know how long these things are going to last. And a big question I have with this, this is a whole separate topic and talk, but I worry sometimes about the TN joint. We have options for the subtalar joint, the tibiotalar joint, but we don't have a lot of options once the TN joint wears out. There's not a way to replace that with a 3D printed device yet that has done a lot. So. One question I did have was, the question of any ankle ligamentous injury and how that's managed for you guys. So, the first case I showed, the lady, obviously, her lateral ligaments were out. I stressed her afterwards and I felt that she needed a brostrom. So we did it because she had a lot of lateral instability. I wonder did that scar her in a little much to where she developed the scar tissue and the lack of range of motion? I mean, any utility to getting an MRI off the bat versus CT? What do you guys prefer from an imaging standpoint with these injuries? I think you're muted again, Chike. I think Chike is having some technical difficulties.
Yeah, I don't routinely get MRIs for acute talus fractures. I think CT scans, if they're displaced, even if they're not displaced, I want to check the CT to see if they're displaced. I just can't see it. So I'll usually get a CT scan for pre-surgical planning. Oftentimes you'll find interposed fragments that could block the reduction, and you'll find fracture lines that you can't see on x-rays that may need to be lagged, an extension of the talar body, like I emphasized. So in terms of imaging modalities, that's what I usually do. I haven't given much thought to doing acute ligament repairs at the time of fixing talar necks. Kind of like you said, oftentimes they get a little stiff, so it's not something I've really worried too much about, to be honest.
Okay.
Actually, a lot of talus associated with a dislocation, a subtalar dislocation, sometimes they do need the ligament reconstruction. Mostly post fixation, we do assess them clinically for any of the instability, signs of instability present. And if we do suspect after fixation, we might try and get an MRI or a dynamic ultrasound to find out if there is any need for stability to be provided later on. At the same
Can you all
time,
hear me
may I
now?
ask you guys, Rishin and everyone, how is your experience with the stem cells or the bone marrow substitutes for the AVN, and when exactly, if you do at all, when exactly do you want to go ahead and intervene in such cases?
I don't routinely do that for AVN stem cells or BMAC or anything like that. I've heard of it being done. I just don't know of a lot of level 1 evidence to support it. Now, that being said, there's not a lot of level 1 evidence to really support anything in the management of AVN for the talus, just because it's not as common and it's challenging to treat, and we just don't have high-powered, high-number studies for it. So I think people that do it and have good success, I think it's reasonable. I mean, it makes sense. It's just not something that I do. I don't know about you guys, Chike or Jay.
Yeah, I mean, I don't think there's great literature on stem cell treatment for, talus fractures, subsequent arthritis, or even AVN. I mean, even in other joints, knee, hip arthritis, there's no real good literature, and the cost is often prohibitive for many patients. So it's not something that I routinely offer. To go back to that point about ankle instability with talus fractures, as a sports surgeon, it's something that I'm always looking for. And I've had a few patients that have had, lateral ligament instability where you note on, injury films that there's a significant amount of varus tilt. I do agree that performing a brostrum to improve stability is something that's indicated. I also think that sometimes you can have iatrogenic instability where you cut through the lateral ligament to structures when you're performing your lateral approach. That's something that, after you fix your talus, you may want to perform a stress exam under fluoroscopy to assess. Another form of instability, which you all have kind of mentioned, is subtalar instability, where at the onset of the injury, there is some evidence of subtalar subluxation. And I think in those cases is usually associated, comminution of the posterior medial process. Those are fractures that are very difficult to treat. I mean, they don't heal well, even if you try to fix them. If you excise them, you exacerbate the instability. So in those cases, I often will go to fuse them primarily while fixing the talus fracture to help maintain subtalar alignment, especially in older patients.
Okay. All right. Well, Dr. Parekh, do we have any questions or any other discussion points? Again, I want to thank you guys for being on this session with us.